Thank you all for coming today. Today's session is going to be about systematic reviews and meta-analyses. Like we said last time, it's going to be in English language. So today we have Professor Murad with us here to speak about this topic. Dr. Murad is a professor of medicine at the Mayo Clinic in Rochester, Minnesota. He completed residencies in internal medicine and preventive medicine and is currently the program director of the Preventive Medicine Residency Program at Mayo Clinic. He has taught for many years the graduate school courses about systematic reviews and meta-analyses in evidence-based medicine in the Mayo Graduate School of Medicine in Mayo Clinic. He leads the Mayo Clinic Evidence-Based Practice Center, EPC, which is a federal designation as part of the AHRQ, Agency for Healthcare Research and Quality. He is a clinical epidemiologist and a methodologist who aims at improving the methods of translational research and integrating the best available evidence in medical practice. Dr. Murad has conducted systematic reviews and meta-analyses and evidence synthesis studies for many years, as he is an international pioneer in this field. He has participated in developing clinical practice guidelines with many professional societies and institutions, mainly the CDC, and NHLBI, WHO, Society for Vascular Surgery, Endocrine Society, the Pediatric Endocrine Society, the American Association of Blood Banks, the American Urological Association, the American College of Chest Physicians, the Undersea and Hyperbaric Medical Society, and the American Association of the Study of Liver Disease. Dr. Murad has over 275 peer-reviewed publications. So Dr. Murad is more than qualified to talk about this topic, as he is an international figure in systematic reviews and meta-analysis and evidence synthesis and guideline development generally. So we're extremely lucky and glad to have him here with us today to talk about this topic. Dr. Murad, can you hear me well?
Yes, I can hear you. You can hear me well?
Yes, I can hear you clearly.
Okay, great. شكرا فارس وشكرا لكل اللي حضرانين هالمحاضرة وللي حيسمعوا النسخة المسجلة منها. المحاضرة حتكون بالإنجليزي and I hope that goes well. I have no disclosures. Our objectives are the audience will become familiar and be able to describe the definition, process, and rationale for systematic reviews and meta-analysis. That will be session 1, which is today. Session 2 will be next weekend, and there we will talk about advanced concepts such as risk of bias, heterogeneity, analysis, models, publication bias, and some other advanced concepts. And at the end of next session, we will talk about a framework or a plan that tells you how to read and use a systematic review and meta-analysis. So there's a question here for the audience. Choose the correct answer. Number 1, a systematic review provides the highest level of evidence. Number 2, you can do a systematic review without a meta-analysis. Number 3, you can do a meta-analysis without a systematic review. And then 2 and 3 are correct, or 2 and 3 are incorrect.
So far, about 50% of the attendees have voted.
Okay, let's see what you have.
Okay, so about 80%. I think I'll stop now. So 28% answered the first question. Systematic review provides the highest level of evidence. 25%, the second answer, you can do a systematic review without a meta-analysis, and another 25% answered that both 2 and 3 are correct. 16% answered 2 and 3 are incorrect, and 6% answered the third answer, you can do meta-analysis without a systematic review.
Okay, very good. Thank you. All right, so after this question, I'm going to talk to you a little bit about this topic, and I think that will answer the question. So you will know which is the right answer. So let's start by defining what a systematic review is and what a meta-analysis is. A systematic review is the process of collecting all empirical evidence that fits a pre-specified eligibility criteria to answer a specific question. I underlined a couple of these characteristics, such as pre-specified eligibility criteria and a specific question, because these are characteristics of a systematic review. And these will help you differentiate a systematic review from a narrative review or a non-systematic review, or essentially just a review article. So the systematic review is the process of getting the evidence. A meta-analysis is the statistical pooling or combining of individual studies to produce a single effect size. So let's say we have 4 studies, for example. Each one has a relative risk. So you have relative risk 1, 2, 3, and 4. Each one is coming from a study. A meta-analysis will produce one relative risk that is pooled. So essentially, it's an effect size that describes the whole population of all included studies. So if you want to remember this by a picture, you can think of a systematic review as the process of selecting the studies, this rigorous process that you see typically in published systematic reviews. And if you want something to remind you of a meta-analysis, think about the forest plots, which includes results from every single study, and then the summary effect or the pooled effect that represents all the studies. And the forest plot has a square in the middle that offers the effect from the single study, and then the line that goes that, which is the confidence interval. If the confidence interval crosses the line of unity, which is the midline, that's the line of no effect, that's analogous to a p-value less than 0.005 or statistically significant results. So this is the basic description of a forest plot. So if you want to think about a figure, just remember this figure. This is what a systematic review is. This is what a meta-analysis is. Now you can do, if you look at this Venn diagram here on the left, so you can do a systematic review without a meta-analysis, and you can do a meta-analysis without a systematic review. So a systematic review without a meta-analysis means you've selected the studies, you followed the rigorous steps of selecting studies, but you did not combine studies statistically. Meta-analysis, so you can pick studies without this rigorous approach, just pick a few studies and summarize and pull them statistically. So you can do a meta-analysis that is based on studies that you picked yourself and you did not pick through a systematic review process. Of course, neither one of these two approaches is very helpful. What we really like the most for decision making is that we have a systematic review with a meta-analysis, which is here in the middle. That would be the most helpful for us to make decisions. This table shows you the difference between a systematic review and a narrative or unsystematic review article. So this is just a traditional review article that you see very commonly in journals. So in terms of the question, a systematic review answers a focused question. So for example, what is the effect of endarterectomy versus stenting on outcomes of carotid artery disease? It's very specific. It's comparing these two things. On the other hand, you may see a review article that has a very wide perspective and a wide focus. So that article may talk about the management of carotid disease in general. So that article will include some discussion about endarterectomy and stenting. Also, we'll talk about aspirin, about other pharmacological interventions, diagnosis, prognosis. So it's a very wide scope. In terms of a protocol, a systematic review has a protocol. A review article does not. So what does a protocol mean? It means a plan that's done before you do your study. So you have a specific inclusion and exclusion criteria, plan for analysis, and so forth. In terms of how the evidence was searched for in a systematic review, it's a comprehensive search. So you have a search strategy and you have certain databases that you go through, whereas for a review article, you just pick the studies yourself. In terms of reproducibility, which means that if I do a systematic review and you do a systematic review following the same protocol, we will reach similar conclusions. And so that means it's reproducible. On the other hand, a review article, I can write a review article on carotid disease and you can write another one, and they can be very, very different. In terms of bias and error protection, a systematic review has steps to reduce bias and errors, such as doing tasks by 2 people in duplicate to replicate the work, reporting kappa, which is a measure of agreement to demonstrate that people are doing the work similarly. So there are some measures like that in a systematic review, whereas in a review article there isn't. So you can sit on your own in a weekend, write a review article, and you're done. And it's hard to tell what errors you've done, and it's really not a reproducible process. So what do we use a systematic review for? We use it for a management question. So a therapy question, diagnosis question. It's when we need to make an action, when there's decision making. What do we use just a review article or a narrative review for? Is to become familiar with the topic. So if I don't know anything about multiple sclerosis, I would like to get a review article that's easy to read, that tells me about the disease in general, about prognosis, prevalence, diagnosis, management. So just to become familiar with the topic. It's more like a textbook. Like if you read about something in Harrison's, for example. If you read a chapter in Harrison's, that's a review article. It is very similar to that. So now I'm going to tell you why we do this. So that's what a rationale means. It means, why do we do this? Why do we want to summarize evidence, aggregate it, combine it, and present it in the form of a systematic review and meta-analysis? I will describe to you 3 cases, 3 stories, and from each one of these cases we will come up with a reason why we want to synthesize evidence. All right, so this is a simple one here. So a randomized trial compared Rosiglitazone to placebo. So Rosiglitazone is a diabetes drug. The trial had 100 patients in each arm, and the primary outcome of the study was hemoglobin A1C, which is a measure of diabetes control. Of course, the patients in the Rosiglitazone group, they had reduction in A1C, whereas the placebo people didn't. So the difference in A1C level was statistically significant. And the conclusion of the study was that Rosiglitazone reduces hemoglobin A1C. So this is a single study. When studies are designed, of course, they do what's called power calculation. So they do power calculation for their primary outcome. So they choose an outcome and say, this is our primary outcome, and to get a significant reduction in this outcome, we need 200 patients, just like this study. However, we are always interested not just in the primary outcome, but in other outcomes, like a secondary outcome. Here is myocardial infarction, MI, heart attack. So in this study, there was only 1 heart attack in the placebo group and 2 in the Rosiglitazone group. So the rate or incidence of MI here is 1% in the placebo group and 2% in the Rosiglitazone group. This difference, of course, is not statistically significant because you have only 3 events here. And the conclusion of the study would be that Rosiglitazone does not significantly increase the risk of MI. So we have this one study that showed us the significant reduction in the primary outcome, and of course the secondary outcome was not significant. But let's say there were 13 studies just like this. So identical studies, they all had the 1% versus 2% rate of MI. So everything is identical. So for MI of all these 13 studies, we have 13 MIs in the placebo group and 26 in the Rosiglitazone group. These are over 1,300 patients in each arm. The rate is still 1% versus 2%. So what I did is I just multiplied these by 13, right? So I multiplied 1 by 13, 2 by 13, and the sample size by 13. The rate is still 1% versus 2%. So do you think this will be statistically significant? Well, it is. And the reason for that, you guys will guess what the reason for that is. But the conclusion of a meta-analysis, of this meta-analysis, will be that rosiglitazone increases the risk of MI. So what happened here is that the individual study gave non-significant results. The summary of 13 identical studies showed significant results with the same exact rate of 2% versus 1%. So why does that happen? It's actually due to the number of events. So precision means the width of the confidence interval of the relative risk is driven by the number of events. So when you have the meta-analysis, you have a lot more power, and then you demonstrate statistically significant results. So this is the first rationale for doing a meta-analysis, which is to improve precision. Again, precision means more power, narrower confidence interval, more statistically significant results. This should be very intuitive, I think, to most of you. A small study cannot find significance. Larger studies or combined studies into a larger study will find statistical significance. So this is the first rationale. Let's move to the second. Here's case number 2. So 33 randomized controlled trials of streptokinase, which is a thrombolytic, in acute myocardial infarction were published over 30 years. So this was from 1959 to 1988. 6 of these trials showed that streptokinase reduced mortality, and that was significant, whereas 27 did not. So the experts disagreed, and the experts did not recommend streptokinase as a routine treatment. So you can understand why experts are in disagreement, right? Because 6 trials showed a reduction in mortality and 27 showed no significant reduction in mortality. So what can we do? Well, the experts disagreed. So some of them would cite the 6, some of them would cite the 27. These are how the trials played out. So you can see the ones here in gray are the ones that were significant. So showed that streptokinase reduced mortality, whereas the ones that are not in gray did not. Just to kind of visualize it, so look at this here, how this is not touching the 1, right? So this is a p-value of 0.01, so this is significant. Whereas this, for example, it crosses the 1, and the p-value is 0.3, so it's not significant, right? So this is how you read a forest plot. So experts disagreed. In 1992, so after all this was published and done, Joe Lau did a meta-analysis that combined all these studies and showed that if you combine all these studies, you find out that streptokinase actually reduces mortality in acute myocardial infarction, and the effect was statistically significant. So you can see that the p-value was less than 5%. You can see that the combined effect doesn't touch the 1, so it's statistically significant. So if we look at this story, what do we learn from this story? Well, we learned that people had to wait till 1992 to actually know that streptokinase was effective. But what if we were doing a meta-analysis every time we had a new trial? So imagine that every time we have a new trial, we conduct a meta-analysis. So here, for example, if after Fletcher finished his trial, this Dewar was doing his trial, he would have finished his trial, and then he would have combined the 2 to look at the results. And then this Euro 1 would combine the 3 and look at the results. So how would that look like? It would look like this. This is what's called cumulative meta-analysis. So this is the first study. This is the first and the second. These are the first three, the first four, and so forth. So if you look at this figure, you immediately realize that the results were statistically significant, probably in the mid-70s. But we didn't know that till the late 80s. In fact, till the 90s, till the early 90s, till Lau did his meta-analysis. So over 30 years, we kept doing randomized trials, and all we were able to do over these 30 years is to make the confidence interval narrower, right? So you can see here it's very narrow, and but even here, it was showing this trend for improvement, and then here it became statistically significant and just getting narrower and narrower. But the effect stabilized pretty much. So, well, so what are the results of this? Well, first of all, we didn't know that streptokinase should be routine treatment for acute myocardial infarction for probably 15 years. So thousands of patients were randomized to placebo for no reason, right? So these patients were harmed, and many of them died because they were randomized to placebo because we didn't know. And outside of these trials in the world, there were probably tens of thousands or hundreds of thousands of people who had acute myocardial infarction and did not receive streptokinase because we did not know. So the lesson from this story is that cumulative meta-analysis here, if it was done, or any meta-analysis, if it was done at different time points, it will tell us what the overall effect is and will prevent this disagreement of experts, right? So some experts would cite these, the gray ones, and give streptokinase. Some experts will cite the white ones here and not give streptokinase. So the moral of this story is that if we take this forest plot and flip it on its side, it looks like a forest, right? It looks like a forest. So the goal here is to shift focus from the trees to the forest. So every tree here is a study, and we really do not want to focus that much on the individual studies and shift focus to the overall body of evidence of the forest. So in terms of rationale, the second rationale to pool studies, to combine studies, to synthesize evidence is to evaluate the body of evidence. So the forest, or the totality of evidence, not the tree. And this is the third and last case that will build up our rationale here. So let's say we have a gentleman here who is 78-year-old, has kidney disease, so renal insufficiency, and diabetes. And this patient presents with high cholesterol. We want to give him a statin. And we found a randomized control trial showing us relative risk of 0.75, which means 25% reduction in the risk of acute coronary event if you use statin. So we want to fit this patient in the inclusion criteria of the trial, right? So fit the patient in the bucket. That's what people do. But it doesn't fit. Why? Because the trial probably excluded old people. So many trials will have an exclusion criteria of people, say, over 75. Or the trial excluded patients with renal insufficiency, or excluded patients with diabetes. So trials have very strict inclusion and exclusion criteria. So if you get a patient in your office or in your clinic that you want to apply evidence from a trial to this patient, it won't fit. It'll be very hard. However, if we had multiple buckets, right, and we have the same relative risk here coming from multiple trials, then we have much more confidence in applying this evidence to the patient. So our patient is more likely to fit across these buckets because maybe this trial included old people but did not include diabetics. Maybe this trial included patients with renal insufficiency but not old people, and so forth. So the inclusion and exclusion criteria of a meta-analysis is much wider than the inclusion and exclusion criteria of an individual trial. So it'll be easier to apply evidence. So the third rationale I will give you is to improve or facilitate applicability of evidence. In other words, so that we apply evidence with more confidence. So this ends the rationale for synthesizing evidence. I gave you 3 rationale from 3 cases. The first one was to improve precision, basically have larger number of patients and events. Second one, to be able to look at the whole body of evidence and not be distracted by individual studies or trees in a forest. The third one is to improve applicability. So these are the steps of a systematic review or meta-analysis. The first step is formulate the question, define eligibility criteria for studies to be included. So this is the protocol, right? We're writing a protocol. Develop a priori hypothesis to explain inconsistency. So a priori means before you do the systematic review, and inconsistency means differences in the results. So before you do the systematic review, you want to anticipate reasons why studies might be different. Conduct the search. The search is usually very sensitive but not specific, which means that we want to capture every possible or remotely possible eligible study, but we do not want to be very specific. So we do not want to have to miss any studies. So we're willing to accept including studies that are borderline eligible in our search, and then after that by hand we will exclude them, but we don't want to miss any studies. Then there's a step of screening abstracts, because you have a very large number of studies, you cannot read all of them. Then those that are likely eligible, you include those. After you read them in full text, you extract the data from the studies, you assess the risk of bias, and then you describe your outcomes and data, and at that point, that's a systematic review. If you want to proceed with meta-analysis, then the steps would be to combine statistically the effect sizes to generate a single estimate and precision around that estimate. You try to explain causes of heterogeneity based on, remember here step number 3 was we developed a hypothesis for differences in results. Now we actually try to test this hypothesis, and then we rate our confidence or certainty in the estimates or in the evidence. So these are the 12 steps of a systematic review and meta-analysis. I will go through these steps very briefly just to expand a little bit on them. So we said we're going to establish a protocol that has our question in the form of a patient, intervention, comparison, outcome. We want to define in our protocol the type of study. So what studies should be included in this systematic review, like a randomized trial, cohort study, case controlled, non-controlled, whatever. So it's based on the question. We want to define the hypothesis for inconsistency and do subgroup analysis, and then consider potential sensitivity analysis. So sensitivity analysis means when you make assumptions, you test those assumptions. So for example, we say that we're including studies in which patients had diabetes, but then one study included patients with impaired fasting glucose. So it's a kind of a step lower than diabetes. Well, maybe that study shouldn't be included. So sensitivity analysis means we do the analysis with and without that particular study to see if the results are different. All right, here's a question to the audience. So when conducting a systematic review about a clinical question, the first statement is, searching PubMed alone can miss up to 10% of relevant studies. And then the options here are can miss up to 20%, 30%, or 50%. So to clarify, so PubMed is a free interface for Medline, and it's offered by the National Library of Medicine. So this is PubMed essentially. If you go pubmed.org, This is your window to Medline. So if you do a systematic review and you only search PubMed, do you think you're going to miss a lot of studies? 10, 20, 30, 50? What do you think? Faris, you probably have enough answers.
So about 75% have answered so far. 37%, mostly the most common answer was the third one, the 30% answer. And then the 31%, the second most common was the second, up to 20%.
Okay, thank you. So when you conduct a literature search, you want your search to be sensitive but not specific. We talked about that. We want to be all-inclusive in the beginning. We strongly encourage you to use a medical librarian because each database has its own inherent characteristics and challenges. So you want someone who's expert in doing that. Multiple synonyms is a must. So a synonym means describing the same concept in different ways. So for example, myocardial infarction, heart attack, coronary disease or coronary event, these are all descriptions of the same thing, so they're multiple synonyms. When you search, you want to search using all these synonyms. For a systematic review, right? So remember in previous sessions in this class, in previous lectures, you talked about PICO and searching. That was not to do a systematic review. That was just searching for finding evidence to answer a question in practice, right? This is much more detailed search. You want to use text words and controlled vocabulary. So a controlled vocabulary, just like mesh terms and M3 terms, these are indexing terms designed by each database, whereas text words are just free words. So we use both of them in systematic reviews. And one database can miss up to 50% of eligible studies. So the question I just asked the audience about how many do you think you would miss if you use PubMed alone, the right answer is up to 50%. So this was demonstrated empirically in searching PubMed and Embase. So basically what does this mean to you is that if you see a systematic review that said, we searched Medline, that's not a good systematic review because searching one database is not enough. Medline particularly targets the English literature. There are about 5,000 journals, and this number is increasing. Embase targets more European journal and non-English journal. It overlaps probably about 60–70% with Medline, at least in 1,000+ journals. It is expensive, so Embase requires subscription. It's very good for systematic reviews of drugs because it has synonyms and routes. So if you search for a drug, you can say intravenously, for example, or subcutaneously, and so forth. And if someone cannot afford Embase, they can use Scopus. So Scopus and Medline probably is very good. It can, maybe you don't need to do Embase if you cannot afford it, if you do Medline and Scopus. Scopus should draw data from multiple databases, but it only has index terms without subheadings, so the search is not as sophisticated in Scopus. ERIC is another database we search for education, so if you're doing education research. CINAHL is for allied health professions, so if the systematic review is about topics that require anything to do with nursing, physical therapy, dietetics, so anything that has allied health professions, so other than physicians or straight medicine, then CINAHL should be reviewed. Cochrane Central is a database that draws manually randomized trials. So this is Cochrane Central, not the Cochrane database for systematic review. This is Cochrane Central. This is for trials. There are regional databases, so LILACs, for example, from South America. So if you're doing a systematic review about an infectious disease, that is very prevalent in South America. You want to search lilacs. There are Chinese databases that you want to search if you're searching for alternative medicine. Google is another thing. So there are a lot of different ways to do the search and be comprehensive. This is why we say a medical librarian will be really good to have. The other part of search is we search non-published literature, or what's called gray literature. So things that are not published in peer-reviewed journals, they may not be in databases. So for example, abstracts presented in conferences. There are journals that are not indexed, so they're not, for example, in PubMed. We ask experts. We look for thesis. So if someone says someone is doing a master's or PhD, they do a thesis, it's archived in their university. The thesis may be an original trial or original study or an observational study. This would not be on PubMed or on any database. So sometimes these we search for. Trial registries are important thing to look at as well. So when someone wants to do a randomized trial, they register it in clinicaltrials.gov, for example. That's the US registry. There's one for Australia and New Zealand. There's one for Europe. So searching trial registries will tell you about which trials were ongoing, which trials were done and never published. So some trials are never published, so you can find them through registries. You can search with the FDA files, so the Food and Drug Administration. That's also very important because drug companies, for example, may do multiple trials and submit them to the FDA to get drug approval, but then they may decide to only publish one. And of course, the one they will decide to publish will be the one that showed the most impressive results. So searching FDA files in certain situations is very helpful. We do what's called hand searching, which means looking at the studies that we included and look at their references and looking at other reviews. Sometimes systematic reviews will have a language restriction, so they will say we only search the English literature. In general, that's not a good thing to do. It's something that I would do only if I didn't have time or money. But if you have the luxury of time and money, you want to look at other languages because obviously you're going to miss a good section of the literature, particularly in French and Spanish and German. The workflow goes like this. So we have the abstracts, we screen those, we pick from them, and we search those in full text review. This process is done usually independently by pairs, so two people will review the same set of abstracts. We check for agreement using kappa, for example. We say like 80% agreement between the two reviewers. Disagreements usually are discussed in the team or they're arbitrated by a third reviewer. We very frequently contact authors of the studies that we are including in our systematic reviews to clarify certain things or ask for missing data. And this is how journals usually publish this figure that demonstrate these steps. So you can see the literature search, then the abstract screening, exclude a large number of abstracts, then you have new studies that you read in full text and extract the data and include in analysis. All right, so that was all about the steps of a systematic review. Now we will talk a little bit about meta-analysis. So again, to remind you, meta-analysis is pooling, statistically combining effect sizes from individual studies into one large effect size that represents the population of all the studies. Effect size is a term we use, so you'll see me using that very frequently. It really means the results of the study. So it could be a relative risk, an odds ratio, or a hazard ratio, difference in means, whatever. But it's just an effect size. So the size of the effect I think it's an intuitive term, but it represents all these different measures. So I will present you now with, again, a rationale for pooling and a rationale for not pooling. So the Stein paradox has been described in epidemiology, and it means that, or it describes when a pooled estimate is more representative than individual estimates, even if real differences between studies exist. So what does this mean? It's saying that here that a pooled estimate is better than individual estimates. So let's use an example. A patient from Rochester, so Rochester is a city in Minnesota, asked about his chance of surviving stage 2 lung cancer. So we have estimates from Rochester, which is a city, about 100,000 people. We have an estimate from Olmsted County, which contains Rochester, which is about probably 200,000 people. And then we have Minnesota data, which is about 4 or 5 million people. And then we have the US data, which is about 300 million. So the question here is, which estimate should we give this patient? The patient is asking about their prognosis from surviving a disease. Now, intuitively, you may think that, well, I should give the patient Rochester data because this is more similar to this patient. So maybe the patient, say, is white, from Scandinavian descent, and is old, right? So this is more likely to be represented in Rochester than the rest of the state. So some people, so you say there's a spectrum, right? So you can go from a very specific population that maybe it resembles the patient more into a very large population that will represent will not be similar to that patient. So the rationale for here is, or what Stein is saying, the Stein paradox is saying that probably the US data is more appropriate to give this patient than the Rochester data. So this is why it's called a paradox, right? A paradox means something that you don't expect, that surprises you. So the Stein paradox tells you that the US data is more representative of this patient. Although the US data may have patients who are Black, who are Hispanic, who are young, who have HIV, who have, very different than Rochester. So Rochester data probably is much more similar to this patient. But still, the Stein paradox is telling you that the US data is more representative. So this is an analogy we're using with systematic reviews and meta-analysis, saying that you should pool studies because this variation in population will give you more confidence in that your patient will actually have a similar match in a very large set of the US data. So now there's a rationale against pooling. And it says that pooling may ignore inherent comparisons and confounders that were controlled for in original trials. So you see here apples and oranges. This is a term commonly used when you pool things that are not similar. So this is a rationale against pooling, saying that no, you should not pool studies in meta-analysis. If you use the analogy of the patient from Rochester, this will tell you no, give the patient from Rochester prognosis from the Rochester population, and give the patient from London the prognostic data from London's population. So this is an opposite argument or rationale, and this is called the Simpson Paradox. So in epidemiology there are these two paradoxes, the Stein paradox and the Simpson paradox, and they argue opposite things. One is more towards aggregating things, combining things, and one is the opposite. It tells you need to find something very specific. So you need to find a study that is very specific to your patient. I will show you in numbers here this Simpson paradox. So this is the paradox that tells you should not combine things. The argument here is that when you combine things, you can find things that are unexpected. So, for example, this is a baseball example. And of course, baseball is not popular in Syria at all, or not popular actually in most of the world outside of the US and Japan and a couple of other countries. But I use it because this paradox became more known through baseball. So there were two players. who in 95, they had a batting average. You can see here 25% for one and 0.253 for the other. So the other player, so this Justice player was better, had more hits. So this second player was better in 2005. In 2006, I'm sorry, in 1996, this patient, say the second player was also better. This is just a simple proportion. So it's 45 out of 140 is 0.321. You can just divide them. So this second player, Justice, was better in 1995, was better in 1996. But when you combine 95 and 96, you find that the first player actually is better. So these numbers, you can verify them, so you can divide them yourself, and you will see, so divide 12 by 48 to 8. So the numbers here are all correct. So this David Justice was better in 95, better in 96, but then when you combine the 2 years, you find that Jeter was better. Right? So this is the Simpson Paradox. It's counterintuitive, it's unexpected. So people, so sportcasters and people who do statistics for sports were surprised. We're like, well, this player is better in this year and better in the second year, but then when you combine the 2 years, he's not better. That's strange. So that's the Simpson Paradox. Now, mathematically, this happens when the success of groups is reversed when they are combined, because actually, so if you look, the reason why does this happen? Actually, it happens because this year, where Jeter, the first player, was not as good, the average of this year, the 31%, is actually better than this one here, which is the first year when the second player was better. So in other words, so the second player was better in the first year and the second year, but in the second year, the losing player had higher average than the winning player of the first year. And when you combine them, you see the number here is much larger. The sample size here is much larger. So this estimate here gets higher weight and show you overall that this player is better. In medicine, you can look at this way. So say there's a treatment A is better than B in small kidney stones. Treatment A is also better than B in big kidney stones. But if you combine all stones, you find that treatment B is better. So this also happens when you combine groups. You get these strange results. And this is a rationale against pooling. So what does this all mean? It's when you're designing a systematic review or meta-analysis, you have reasons for not to pool and reasons to pool. You need to choose the right approach. So some of the recommendations that we have is to pool similar PICOs, so similar population, intervention, comparison, outcomes, and study designs. And we pull these similar PICOs expecting that we will find similar treatment effect. So again, I showed you the Simpson Paradox, where you have these strange results that you find when you pool things. This wouldn't happen if the populations were very similar, right? So that's one way to approach that. The other thing is to pull the summary data that incorporates the inherent comparisons instead of pulling the actual event. So if I go back to here to the baseball example, instead of pulling these numbers here with these numbers to get these numbers, instead of doing that, it would be better if I pull this, the 0.253, the percent or the incidence, with this. So if I pull this and this to get a combined effect, and pull this and this to get a combined effect, I probably would not have these strange results or these confounded results. All right, so the best approach is then another way to overcome this unusual results is to pull summary data. like the incidence, for example. So to pull the actual effect size, but not the actual event. And then the last advice about pooling is to pool and explore subgroups by interaction testing and meta-regression, some other advanced statistical methods. So what does this mean is we pool, let's say we pooled studies and we've done the meta-analysis, but then in that we would look at separately, say at patients with diabetes and without diabetes, for example. Patients with renal failure and without renal failure. So if we do these subgroup analysis, we protect ourselves to some extent from reaching these strange conclusions when data are combined. All right, so now this is going towards the end of our talk, and I will just demonstrate to you with numbers how meta-analysis is done. First, we have a question to the audience. When doing a meta-analysis on 5 studies, and each study provides its own relative risk. The first statement, the pooled relative risk is the mean or average of the 5 individual relative risks. The pooled relative risk is closer to the relative risk of the largest study. The pooled relative risk is closer to the relative risk of the study with the least risk of bias. The pooled relative risk always has a p-value smaller than that of any of the individual 5 relative risks.
About 1/3 of the attendees have voted. Waiting for the few more. Okay, about 2/3. The most common answer was the first one, 38%. The second common answer was the second one. The pooled relative risk is closer to the relative risk of the largest study. And 21%, the third most common answer, was the fourth.
Okay, thank you. All right, so here's how this will play out. So let's say we have a study comparing beta blockers to placebo after acute myocardial infarction. We have people who died and people who are alive. So we have 10 who died in the beta blocker group and 60 in the placebo, 100 who are alive here. So how do we calculate the relative risk? So the relative risk is 10 over 110, right? So you basically get the incidence or the risk in the beta blocker group, and then it's 60 divided by 100. That gives you the risk in the other group, and you divide the two, right? So it's the risk with the intervention over the risk with the control. So the relative risk here is 0.24. All right, let's say we have 3 studies. So 3 2x2 tables. Each study, we estimated the relative risk. How do we combine those? So one option is to put them all in the same 2x2 table, right? So you take this 10 plus 15 is 25 plus 80 is 105, and you take all these and put them in this cell. And you do the same for all the other cells. So essentially, you just converted these 3 studies or 3 trials into one trial, and you get the relative risk on that. So what's the problem with that? Now, usually I ask audience for their explanations, and we do not have the luxury of doing this here. But many of the audience would say, well, this will cause the Simpson paradox that you just described to us earlier, right? Because we are combining the actual events. So we lose the comparison. So each study here has its own comparison. By just dumping them all in individual cells, we lose this inherent comparison. So here you can get something like the Simpson paradox. So this will not be a good way to pool the studies. Okay, so we don't want to do that. How about if we just average them out, right? So a lot of you answered the question by choosing the first answer, which is just to get an average. So these are the three relative risks. We take them, we add them, and divide them by 3. And just get the average. So what's wrong with that? And I usually ask the audience, why do you think we should or should not do that? And then you may get different answers. Some people may like doing that because it's simple. But then eventually you'll find some of the audience saying, no, you cannot do that because this study has only a couple of hundred patients in it. And this study has almost 3,000 patients in it. So it doesn't make sense to average them out and give this study the same weight in estimating the mean as this study. So this doesn't make sense, right? So you cannot average them out and have a study with 100 people and study with 5,000 people. You cannot average them out because the study with the larger number of patients, this is the one that theoretically is giving you the best estimate, the most precise estimate that represents the population. Of course, assuming that risk of bias is the same and all the studies, the study characteristics are good, and the only difference is size, really. If the only difference is size, then we would want the larger study to have more weight. So this is not good either. So what's the solution? How can we pool studies? So the best solution is to weight studies by how likely they generate an effect size that is true or close to the real effect size. So we need to weight and give them a weight. When we average them out, we need to give them a weight. And what is this weight? What should the weight be? Well, the best approach that's been used is to use the inverse of the variance. So weights are based on precision, right? So we want to give the bigger study that has more likelihood to represent the real effect a larger weight. So the variance represents the lack of precision or the opposite of precision. Therefore, if we use the inverse of the variance, we will get a very good estimate of the weight. Okay, in other words, so let's just say that in other words. So the variance, so I don't know what kind of a statistical background you have, but a variance is a measure of how much variability is in the data. A study that's usually small usually has a very large variance. So if we use the inverse of the variance, so this is the inverse of the variance, and use that as a weight, this will punish the small studies and will give more weight to the larger studies. So this is the best approach, is using a weighted mean. So the people who answered number 1 question to the answer to the question that meta-analysis is the average or the mean, that's incorrect because it's really a weighted mean. And if you look mathematically at what it is, so from every study, if you have case studies, and you have every study that has a effect size, which is y, and a weight, which is the inverse of its variance. So you multiply the weight by the effect size, and you sum those. So sigma means sum, and then you divide that by the sum of the weights. That's how you get a weighted mean. That's how you get a weighted mean in any time. That's not just in meta-analysis. Anytime you want a weighted mean, you find a weight and you get the sum of the product of the weight and the variable, and you divide that by the sum of the weights. So this is simply what meta-analysis is. It's taking effect sizes from the individual studies, right? So we're taking the effect size, we're not taking the events because we don't want the Simpson Paradox. So it's taking the effect size from the study and using a weighted mean approach in which an inverse of the variance is used as a weight, we get the weighted mean and get the pooled effect size. Of course, there are much more statistical variations and advanced models that we're going to talk about next week. We're going to talk about the fixed effect and the random effects model. So there's some variation to this, but basically it's the weighted mean where the weight is the inverse of the variance. So in summary today, what did we talk about today? So we defined what a systematic review is, and we defined what a meta-analysis is. We provided rationale for evidence synthesis. So I gave you 3 cases in which each case gave you one rationale to synthesize the evidence and combine it. The first rationale, if you remember, was to improve precision. The second rationale was to look at the totality of evidence. And the third rationale was to improve applicability of evidence. We described the process of a systematic review and described the different steps. We talked about the protocol, the search. We talked about selection of the studies in duplicate and so forth. And then we described the basic principle of pooling the effect size across studies. And I gave you 2 principles in epidemiology, the Simpson one that tells you should pool studies and aggregate data and use aggregate data, and then the Simpson Paradox, which was the opposite, which tells you shouldn't. And then I told you that in a meta-analysis, it's a decision that is made based on these 2 paradoxes and finding a happy medium or a good approach that allows you to combine studies in which the effect is similar across the PICO. So across the PICOs of different studies, you have similar effect, and then you can weight the studies using inverse of variance, for example, and get weighted mean. And that's the meta-analytic estimate. And that's all I had for you today. Thank you.
Thank you so much. This was a great lecture. I hope the attendees were able to make the best of it and see how important this topic really is. I think this is a great opportunity to learn from the experience of Dr. Murad in this regard. We had a great turn up today with the number of attendees, and hopefully the number will be even larger even next time. So please, all of you, just make sure to be there next time and tell people that are interested in this field to also attend. So we will be meeting next Saturday again with Dr. Murad as well to continue with this talk. This session will be recorded and will be posted to YouTube as well, like always. So we will meet again. If you have any questions, just post them on the student Facebook group. Thank you all very much.